The following is a lecture on pericardiocentesis. Some of the video clips and materials were found via online research and have been incorporated for education purposes only. As you might have guessed, your patient, after being stabbed in the chest, is suffering from cardiac tamponade. You can also assume that arrest is imminent. In the 2017 Patient Care Guidelines, pericardiocentesis is included as a paramedic intervention for exactly this scenario. Although thankfully rare, death from traumatic tamponade is a survivable injury, and pre-hospital providers are quite capable of performing this life-saving procedure. Let's look at the technique and other important elements of pericardiocentesis.
Pericardiocentesis is indicated as an emergency procedure in patients with cardiac tamponade. Accumulation of fluid within the non-distensible pericardial sac can increase pressure on the heart, leading to impaired cardiac filling and decreased cardiac output. The use of emergency pericardiocentesis to aspirate the fluid can be a life-saving procedure that restores normal cardiac function and peripheral perfusion.
The indication for pericardiocentesis is limited and therefore very simple. If you think death is due to chest trauma, decompression of the pericardial sac is reasonable. Now, we must understand that there are instances other than trauma that can cause cardiac tamponade. A patient with cancer, for instance, might develop fluid within the pericardium, and maybe even enough to create tamponade. At this juncture, though, pre-hospital protocol permit pericardiocentesis for traumatic arrests only. The rationale for performing pericardiocentesis is to relieve the compressive force of pericardial blood so the collapsed ventricles can, of course, re-expand, fill with blood, and start pumping again. Symptoms of cardiac tamponade include Beck's triad. We typically will not see all three, and quite honestly, considering we will be performing pericardiocentesis on those who have arrested, most of the symptoms of cardiac tamponade may not be very helpful. There will be scenarios, however, where chest injury patients who are alive in front of you will display some actual symptoms before they decompensate. Here are some of those symptoms: tachypnea, tachycardia, and then of course PEA, specifically the narrow complex variety. Preparing pericardiocentesis in these cases and in anticipation of arrest might save a life.
The classic presentation of patients with pericardial tamponade includes Beck's triad of jugular venous distension, distant heart sounds, and hypotension. Most patients will have at least one of these signs. All three rarely appear simultaneously and then only briefly before cardiac arrest. Other signs of cardiac tamponade may include a pulsus paradoxus greater than 10 millimeters of mercury, an electrocardiogram with a low voltage QRS or electrical alternans, or a chest radiograph with an enlarged cardiac silhouette. Recent clinical studies report that dyspnea and tachypnea are the two most common presenting features among patients with cardiac tamponade. The rate of pericardial fluid accumulation has a sizable effect on the rate of clinical decompensation. A patient with a rapidly accumulating pericardial effusion may present with severe respiratory distress, agitation, tachycardia, and hypotension before his condition quickly progresses to obtundation, bradycardia, and pulseless electrical activity.
Shortness of breath in these circumstances is a result of both poor perfusion to the lung tree and heart, and of course from fluid backup due to the impaired cardiac output. Reiterating this narration, the most common signs and symptoms of cardiac tamponade include tachycardia and tachypnea along with dyspnea. JVD, muffled heart sounds, and hypotension are helpful if present but not typically witnessed by pre-hospital personnel. Much more likely is the provider seeing narrow complex PEA and probably low voltage QRS complexes. The decreased amplitude is a result of electrical current passing through a liquid medium, in our case blood, before it reaches the leads of your EKG. The current is dampened and shows up as low voltage on your tracing. Now let's examine the actual procedure.
Pericardiocentesis. If available, use EKG monitoring during the procedure. The insertion site is just to the left of the xiphoid process. Prep the skin. Insert the needle at a 45-degree angle. Aim the needle at the scapula. If blood returns, advance the catheter over the needle, then remove the needle, leaving the catheter in place. Then aspirate the rest of the fluid. Leave the catheter in place for additional aspirations if needed.
As you advance the needle, monitor the electrocardiographic tracing for ST segment elevation, which indicates that the needle has been advanced too far and is in contact with the myocardial surface. If this occurs, withdraw the needle until ST segment elevation resolves, then redirect the needle to obtain pericardial fluid.
Now we can cover the Kenosha County EMS PCG. Providers must make certain the landmark for needle insertion is as close to the specified location as possible. That is, just left of the xiphoid and at the junction between the xiphoid and the associated connecting rib. Of course, in the pre-hospital environment, with all the noises, distractions, and intensity of this scenario, palpation of such a small area can be difficult. In the future, handheld ultrasound will be economically reasonable and will assist you in this procedure. Until then, you can practice finding this spot by palpating it on yourself or colleagues, with their permission, of course. Once you've satisfactorily located your entry point, the needle angle should be at 45 degrees. Too steep and you might go below the pericardial sac. Too shallow and you will not enter the mediastinum. How about an example now? Motorcycle versus auto. 40-year-old male in the roadway not moving. Bystanders report patient initially conscious, complaining of chest pain and difficulty breathing. First responders add that the patient was very agitated and became unconscious. Rapid trauma assessment reveals no obvious massive bleeding, airway with blood in the back of the throat, obvious chest wall trauma with no spontaneous rise and fall. EKG monitor shows narrow complex PEA at 20 beats per minute. That finding, along with his obvious chest trauma, and finally bystander report that the patient was initially awake and was having tremendous difficulty breathing before collapse, all support the possibility of cardiac tamponade. Of course, tension pneumothorax is in your differential as well, which is why the updated PCG for traumatic arrest includes bilateral needle decompression along with pericardiocentesis. You prepare your needles. One of the two decompression needles for pneumothorax proves helpful. Your pericardiocentesis also produces its desired effect, and the patient regains pulse and blood pressure. You package the patient and begin rapid transport. If possible, leave the pericardiocentesis needle secured to the chest in case blood reaccumulates and cardiac tamponade occurs again. Now, let's summarize. In the event of presumed traumatic cardiac tamponade, it is reasonable to place a needle into the patient's pericardial sac. Our goal, to aspirate blood, will allow the compressed ventricles to resume normal contraction and filling. Symptoms that warrant pericardiocentesis might be vague, since the patient will more than likely be unconscious and without pulse. Should you encounter JVD and narrow complex PEA in the face of chest trauma, be prepared to intervene. Patients who are alive but displaying features of impending arrest might exhibit low voltage QRS complexes on the monitor, tachypnea, tachycardia, muffled heart sounds, and hypotension. This procedure is frightening. Luckily, it is performed infrequently. If you train properly and remember that your patient can only benefit if they have already arrested, you may develop greater confidence and even save a life.